Good morning, ladies and gentlemen. A warm welcome to you all on this sunny Sunday morning, 8:30. I'm very glad you're here. This is an interactive session dedicated to pitfalls in brain imaging, and I will cover the first part of this session on CT. The purpose is it is an interactive session, so it means please log into the system so you will be able to vote and answer the questions that we will ask you to answer. Okay. So let's start pitfalls in brain imaging, CT. I first would like to give credits to my colleagues of the Antwerp University who share cases with me, because what I will show you is not only cases that I collected myself, but also my good friends collected and shared with me. After a short introduction, I will have some philosophical discussion with you and some theoretical reflections, and then, of course, we will come to the real cases. Cases that will show false negative results, false positive results, and most of them because they reflect normal anatomical variants that may mimic disease, and you should be aware of and not take them for real diseases. I also will show you some artifacts that can mimic intracerebral diseases. I think that most of you are aware that the majority of emergency CT studies that are performed are done by young radiologists, junior radiologists, people in residency, and most of these studies are brain scans. Most of the time, we are confronted with real life-threatening conditions, like patients presenting with an ischemic stroke, subarachnoid hemorrhage, cerebral edema, etc. So it means that misrecognition of often subtle abnormalities can have big consequences if the patient is not treated appropriately. And it may worsen the patient's outcome if we miss one of the diagnoses. Actually, errors in interpretation can be categorized in two forms. We can have perceptual errors, or we can have cognitive errors. If we start with the first category, the perceptual errors, it has to do because the radiologist does not see the abnormality in the images. So it will result in a false negative interpretation. And examples, and I will show you later on, are typically basilar artery thrombosis, a deep cerebral venous thrombosis, PRES, etc. The second category are cognitive errors. The radiologist is looking at the images. He sees something and he's not quite sure whether this really reflects an abnormality or it is a normal variant. Actually, this will result in false positive interpretation of the examination. One of these typical normal variants include, for instance, prominent perivascular Virchow-Robin spaces or prominent arachnoid granulations of Pacchioni, and also calcification and lipidol droplets after previous lumbar puncture and myelography can give normal variants that may mimic disease. This is such an example, an actual CT slice which shows an hypodense lesion over here in the basal ganglia. If you do MR, you will see it would follow the normal signal intensity of cerebrospinal fluid. So this is not an infarction, this is not a lacunar infarction, as you might have thought, but this is a normal variant. This is a giant perivascular Virchow-Robin space. CT examination of a patient who presented with a trauma. We see over here a hypodensity in the right transverse sinus. It could be interpreted as being sinus thrombosis. However, it is not. It is a typical location where you can find giant arachnoid villi of Pacchioni, and they may not be mistaken for a venous thrombosis, like you can see in this patient where you see there's this hypodensity in the sigmoid sinus. This is the normal variant. So you really see they can really look alike, and it's also very important to correlate the imaging findings with the clinical information of the patient. Brain calcifications are very frequently found, and already after the age of 25, 30 years of age, you may find calcifications in various locations into the brain. One of these typical locations is the choroid plexus, globus pallidus, the pineal gland, the phalanx, and also when people get older, you will find vascular calcifications. This is a patient, a normal patient, in which you see there is bilateral calcification of the choroid plexus in the trigonum of the lateral ventricles. Here's another patient. She had coiling of a ruptured aneurysm. You see artifacts coming from the coils within the aneurysmal sac. We also see there are other abnormalities over here. It's slightly asymmetrically, but typically you see it in the median sylvian fissures, and these hyperdense structures, they represent lipiodol remnants. Some little words on artifacts. Artifacts can be divided in different categories. They are physics-based, they can be based to the patient, or they can be related to the scanner itself. One of the typical physics-based artifacts, I'm quite sure you know all of them, are these typical beam hardening artifacts which you encounter in the posterior fossa. Fortunately enough, the industry wanted to get rid of these artifacts, and they developed what is called a PFO, a posterior fossa filter, to get rid of these artifacts. Other artifacts that are patient-related have to deal with motion artifacts, sometimes also with metallic implants. Of course, in the brain, you don't have these metallic implants, but I just showed you the case of the patient with the coils. And you can imagine that if you have a patient that has a clip because of an aneurysm that had ruptured, it also will give rise to artifacts. Finally, we have the scanner-based artifacts, and sometimes this can be very annoying, as in this case of a patient we saw with ring artifacts, as a patient who had a trauma, and we did a CT scan in him, and as you can see, there's a lesion over here in the middle of the brainstem. These are more images in the same patient. There's also some movement artifacts, but you see in the middle of the brainstem, we see this typical ring artifact which is going through all the slices. And this had to do because of dirt on the collimator window of the scanner. If you're interested in these artifacts, I really can suggest you to read this paper that was published in Radiographics some years ago, which gives a nice overview of all the different artifacts that will be encountered on CT imaging of the brain. But now we come to you. False negative results, that is things we want to avoid. CT versus MR. The next presenter, Professor Daniela Preyer, will go with you into detail in things that can be mistaken on MR imaging. I will deal with you on CT imaging. I think most of you, if you would have the choice to perform CT or MR, I think most of you would say, yeah, MR is definitely better, it's more sensitive, you have more possibilities than compared with CT. But I think you all will agree, if you want to rule out hemorrhage, if you deal with patients that suffered from a traumatic brain injury, or when you want to look for calcification, or you want to look into detail at bony lesions, I think most of you would go for CT and not for MR. However, sometimes when we have to use the CT scan, sometimes we have the feeling that we are only looking at the tip of the iceberg, and sometimes we think, do I miss something in this case? And I'll show you this test case. It's a 28-year-old woman, and she's admitted to the emergency room because of worsening headache. She's had facial asymmetry, some drooping of the face. She's a little febrile, somnolent, On the laboratory, we find some inflammatory parameters. Lumbar puncture was performed and was negative. This is the CT scan. I want you to look carefully. 3 axial slices with almost symmetrical aspect of the basal ganglia. Hyperdense vessel sign, question mark. No hydrocephalus. So actually the CT scan was reported as being negative. This is the MR examination. This is FLAIR, T2, and diffusion-weighted imaging. There is no infarction, so there was no hyperdense vessel sign. However, if you look carefully on the FLAIR imaging and also on the T2-weighted imaging, you see there is some slight asymmetry. The gray-white matter differentiation is more pronounced at the right side. There is some swelling of the cortical gray matter. We did also MR venography to rule out venous thrombosis, which shows a normal aspect of the different sinuses. Actually, the diagnosis in this patient was hemiplegic migraine. Her younger sister, she experienced a TIA some years before, and actually she was diagnosed with a disease which is very typical and which shows abnormalities in the anterior temporal poles of the cerebrum, will also show some aspecific white matter hyperintensities. This is a case of CADASIL. And hemiplegic migraine, as in this case, may be the first manifestation of CADASIL. So if you do CT scan, you will see nothing at all. MR is much, much better in this case. Finally, just to show how most of us are looking at images. Most of us will look for asymmetry. And if you look for asymmetry, then sometimes it's easy to make the diagnosis. If you find asymmetry, then you will say, this is the normal site, this is the affected site, which is not normal. However, many diseases may present with symmetrical abnormalities. And I took this example to show you. These are bilateral isodense subdural hematomas taken from the paper from Downer and his colleague, showing that if the disease will show symmetrical abnormalities, it will be very difficult for you as a radiologist, and it can be tough to find the abnormality. So now we really go for voting. I will show you 6 actual CT slices, and you have me to tell which is a patient with normal aging. So here are the images. This is 1, 2, 3, 4, 5, and this is 6. And now you have to tell me which case is the abnormal one. It's time to vote. I'm sorry? Okay. Okay. I think most of you made the right answer, because case 5 indeed is the normal aging process. Case 1 is the X-linked adrenoleukodystrophy. Case 2 is a typical case of PRES, where you see low density reflecting vasogenic edema in the white matter in the typical posterior location. No, I'm telling you wrong things. Number 4 is the press, where you typically see the vasogenic edema in the posterior aspects of the hemisphere. Case 2 is a patient with a lymphoma, where you see a mass lesion in the splenium of the corpus callosum and with associated vasogenic edema in the white matter. Case 3, where you nicely see hypodensity symmetrical in the external capsule. If you see this external capsule invasion and also symmetrical abnormalities in the anterior temporal poles, this is typically a case you should think about CADASIL. 5, as I told you, is the normal aging. In case 6, we see scattered hypodensities in the whole white matter. And if you would do MR, you probably would find microbleeds in this patient, and this is a case of chronic hypertensive encephalopathy. So actually, you were completely right that case 5 was normal aging. I discussed with you about the possibilities of CT, and I made a comparison with MR. Of course, there are some tips and tricks that we can use. Sometimes you should use proper window settings and not rely on the standard window settings that are brought by you by the vendors. And also, I cannot stress this enough, that it is important to make reformattings or reconstructions in the sagittal or coronal plane. These are the standard window settings that are given to you, the brain window settings, with a window width of 100 and a window level of 40. Bone windows settings in patients with trauma or when you look for calcifications. But if you look for stroke, it is very important that you use narrow window settings. And you narrow the window width to 40. Or when you look for small subdural hematomas, you should do the opposite and use large window settings. And you change the normal window width of 100 and change it until 250 or something like that, and you will better appreciate the pathology. This is a case of a woman who presented with aphasia, and this is the CT scan that was performed. If you adapt the window settings to a narrow window setting to look for stroke, I think it's clear to everyone that this ischemic lesion in the right cerebral hemisphere is much better appreciated than when looking at the standard window settings. This is a case I saw last week. It's a patient presenting with a hydrocephalus, as you can see. The ventricles are much too large. There's a lesion over here, a hemorrhagic lesion over here. So how can we explain this hydrocephalus? If you look carefully, you will notice that here we see some sedimentation level in the occipital horn of the right lateral ventricle. So there is hemorrhage into the ventricle. If you look closely and we make reformattings, then you will see there is also hemorrhage in the aqueduct. And this hemorrhage in the aqueduct, this clot, will cause the obstructive hydrocephalus in this patient. And here you see the hemorrhagic lesion, which proved to be a primary glioma of the brain. Clinical information is very important. I think most of you are aware of that. It can be very useful, but sometimes it can also be misleading, as I will show you in the next case. It's a 1-year-old boy. He's admitted to the emergency room with febrile seizures, and is diagnosed with a varicella pneumonia. I was called, I was on call, and I was asked to do CT scan to rule out encephalitis, also in the case of a pre-lumbar puncture. And here is the CT scan of the patient. Look carefully, and then I will ask you some questions. So 1-year-old boy, seizures, varicella pneumonia, encephalitis, question mark. What are your thoughts about this? Maxillary sinusitis, it's a torch infection, We deal with acute disseminated encephalomyelitis as a complication of the varicella infection. We deal with hypoxic ischemic encephalopathy, or we deal with a congenital condition. Excellent. I think you all had a very good sleep this night. As most of you brought up, this indeed is a case of tuberous sclerosis complex. And actually, it was just this infection to the lungs and his seizures that brought him to the CT scan. And so this was the first diagnosis of the tuberous sclerosis complex. As you might know, tuberous sclerosis complex, typically these children are having seizures, and this goes with the diagnosis. As the clinician was thinking, also acute disseminated encephalomyelitis can give rise to the abnormalities that were described. So here you see a recapitulation of the case in which you see these tiny calcifications in the periventricular areas. You see these hypodense areas in the subcortical white matter reflecting cortical tubers, subependymal nodules. If you see these are the typical manifestation of tuberous sclerosis complex. And if you do MR, of course, you will see the abnormalities are better delineated. Differential diagnosis, the torch infections, where you should also look for calcifications in the parenchyma. Most of the time, we are looking for congenital CMV infections. As you can see, calcifications, calcifications, calcifications. These are the things to look for. Also, hypoxic ischemic encephalopathy may give abnormalities, but they are more and will show larger abnormalities, symmetrical. This is always, if you see symmetrical abnormalities, you should think about toxic and metabolic abnormalities. You see hypodense aspect of the brain parenchyma, white cerebellum. This is typically what you will encounter in patients with hypoxic ischemic encephalopathy. Very vulnerable structures in the brain are the deep gray nuclei. This is a case that was given to me by my colleague Paul Parizel, in which you see the abnormalities bilaterally in the lentiform nucleus and also bilaterally in the thalamus. If you do diffusion-weighted imaging, it will show restricted diffusion with high signal on diffusion and black signal on ADC. But as you pointed out, the correct diagnosis was tuberous sclerosis complex, which is a neurocutaneous syndrome. Also, it was called Bourneville's disease or Bourneville-Pringles disease. And as you see, it has typically facial lesions. Patients present with seizures, and when they get older, they will manifest with mental retardation. Just another example on CT and MR showing these typical calcified lesions in the periventricular area, showing hypointensity on MR images. So your diagnosis was correct. Okay, let's move to the next case. It's a 43-year-old woman admitted to the emergency room. CT is performed. Clinical inflammation, very typical. I think it's no different in Belgium than from other countries. They are very sparse with the clinical inflammation most of the time. So on the demand, the clinical information was rule out stroke, rule out seizures. And this is the CT scan that was performed. So again, looking for stroke. Is there a cause for seizures? My question to you is, what is the affected site? Is the abnormality at the right side, or is the abnormality at the left side. Okay. Most of you thought the abnormality was on the right side, and that is correct. However, as you can see, almost 35% of the audience thought the abnormality was on the left side. Maybe we should go back to the case. So these are some of the images, and if you look carefully, you will see we have a small dot of hyperdensity in the right sylvian fissure. This small dot reflects clot in the peripheral aspects of the middle cerebral artery. So this is the middle cerebral artery infarction. And if you do the reformatting, you see that you see the vessel better. So it's important to do, in these cases, make reformattings. It will help you. Also, use proper window settings. As I stressed you before, use these 40 window width, window levels, and then you will see that probably there is some hypodensity here in the subinsular region. So those of you who thought the abnormality was on the right-hand side, they were right. MR was performed some days later, and you see from the restricted diffusion over here, this is a peripheral middle cerebral artery infarction. How was it caused? It was clot coming from a dissection of the right internal carotid artery with thrombosis of the internal carotid artery, as you can see from these images. A very interesting publication from the group of Mullins is if the clinical people would give you more information, we would score better. And actually, they found out if you are blinded to the clinical information telling you this patient has a left hemiparesis, this patient has an aphasia, it increases sensitivity from 35% up to 65%. So the abnormalities in early stroke are very subtle. So you should look for these subtle abnormalities, but you will score better if the clinician would give you the proper information. I think most of you know the hyperdense vessel sign in the more proximal part of the middle cerebral artery, which is called the hyperdense string sign. However, when the abnormality, when the clot is more at the periphery of the artery, it will only show a small dot in the sylvian fissure, and this can be easily misdiagnosed, as was the case in our patient. Of course, you can imagine if the clot is proximal, that the result, that the infarction will be much bigger than when you have an embolus in the distal part of the middle cerebral artery. This is just another example, a similar-like patient in which we see there's a hyperdense vessel sign in the proximal aspect of the middle cerebral artery that can give rise to a much bigger infarction, as you can see in this case, where the whole middle cerebral artery territory is infarcted, including the deep gray structures. Sometimes, if the clinicians are not telling you where the abnormalities, there is a simple trick to remember, and this is Prevost signs. I think some of you might remember from their studies in neurology that the patient is looking at the affected site. And I would ask you when you're home tomorrow or the day after, and you have a patient with a stroke, look at the eyes of the patient. You clearly see that the patient is looking at the right-hand side. This is the patient that I showed you before with the big middle cerebral artery infarction, and the patient is looking at the site of the infarction, and this sometimes can really be helpful. The next case, it's a polytraumatic patient having CT scan of the brain, the C-spine, the thorax, and the abdomen. And these are the imaging findings. Actually, everything was normal, except for the imaging study of the brain. I was called by the resident in training. He said, Dr. van den Hauwe, can you have a look at this study, because I cannot explain there is air in the third ventricle. How can we explain there is air in the third ventricle? Do you think that the abnormality that you see, air in the third ventricle, it's a correct statement or it is not? Okay, good. I think most of you did not trap in this question. And actually, of course, this was not air in the third ventricle. There are two ways to solve this problem. Or you put a ROI in the density abnormality, and then you would see that the measured density is not the density of air, but is the density of fat. Another way to solve the problem is just, as I told you before, make reformattings in different planes. And if you make a sagittal reformatting, then you will see that the abnormality is following the curve of the corpus callosum. So this is a typical case of a lipoma of the corpus callosum. Okay, this is the next case. 7-year-old girl, failure to thrive, anorexia and vomiting. Recent previous medical history of an ear infection. Now having a headache. And if you look at the patient, the ear is red. There's also signs of meningisms, and CT scan is performed. Some images. So this is my question. This is a child of 7 years old of age. We are confronted with acute middle ear disease, cholesteatoma, dural sinus thrombosis. This is a typical case of Dolmetsch syndrome. And could it be Griesinger's sign? Time to vote. Okay, excellent. I think this is a tough one, because one of the difficult problems to solve is rule out patients with sinus thrombosis. And when you're confronted with a possible child with a possible dural sinus thrombosis, you will do any effort to make sure you don't miss the diagnosis. So very good of you. So actually, it was not chronic medical ear disease. There were no clinical symptoms, although CT showed blurring of the mastoid cavity. If you would look for a cholesteatoma, I think most of you would perform MR with non-EPI diffusion-weighted imaging, as was described by my fellow countryman Bert de Voer, who published a lot on diffusion-weighted imaging in patients with cholesteatoma. Looking for possible diagnosis, I was thinking about Dolmetsch syndrome. I was here in 1991, which was my first ECR meeting, and going down the stairs, when you go to level -1, I passed this door, and it said Dolmetscher Technique, and I didn't know what it was. So I found out that actually Dolmetscher is the English word for, or the German word for interpreter. So dural sinus thrombosis is very frequently, and especially in children, associated with otomastoiditis and is a life-threatening condition. In the same child, we performed MR, which showed normal aspect of the superior sagittal sinus in the straight sinus, but showed a clear abnormality in the right sigmoid sinus. And one of the sequences which is also very sensitive to pick up dural sinus thrombosis is diffusion-weighted imaging, where the clot will show restricted diffusion with high signal on diffusion-weighted imaging and a black signal on the ADC maps. Actually, Griesinger's sign, which is referring to edema in the post-auricular soft tissues, this is typically what this patient had, and is due to a thrombosis of the mastoid emissary vein. And I will show you on this slide, this canal is the mastoid emissary vein canal, and there's a small vein running through this. When it gets thrombosed, you will have reddishness of the ear, and you will have edema in the auricular soft tissues. So actually, Griesinger syndrome was, or Griesinger's sign, was the correct diagnosis, together with dural sinus thrombosis. Okay, let's move to the next case. A 50-year-old woman, progressive tetrapyramidal signs, more pronounced at the right-hand side. Patient is confused and disoriented. This is the CT scan that was performed in the acute phase in this patient. After contrast. So this is my question. This patient is presenting with a bithalamic tumor. We are dealing with hypoxic ischemic encephalopathy. Is this a case of Creutzfeldt-Jakob's disease? Is this deep cerebral vein thrombosis? Or is this a cerebral abscess? It's time to vote, and I will show you the images again. Excellent. Congratulations. I think most of you voted for D, which is deep cerebral venous thrombosis. And as I explained to you before, this is really a life-threatening condition, and it should not be missed. So if you see a case like this, when you have vasogenic edema in this area, the deep basal ganglia, if you have a dense aspect of the sinus, like you see over here, you should consider the diagnosis of deep cerebral venous thrombosis. I already showed you this case. It's not hypoxic ischemic encephalopathy. Also, Creutzfeldt-Jakob disease will not most of the time present in this matter. It will typically have these hockey stick abnormalities on MR imaging. This is the MR image in our patient, which better demonstrates the abnormalities, because on CT The abnormalities in the left thalamic region were very obvious, whereas that the abnormalities on the right side were less pronounced on the CT imaging. Sometimes it can mimic an abscess, like you can see over here, where you have a ring-enhancing lesion with restricted diffusion. So you should really try not to miss this. This is another case of an abscess, which show a hypodensity in the right thalamic region. It's hyperintense on flare, some enhancement, and we see restricted diffusion on the images. A nice paper if you want to evaluate bilateral abnormalities in the deep gray nuclei. Please read this paper. I really can recommend it to you. So the correct diagnosis in this case was the deep cerebral venous thrombosis. This is the next case, and maybe it will be the last case. It's a 47-year-old patient, and she was found by her son. He heard his mother yelling at 8:10 p.m. sharp. She was confused, was talking incomprehensible language. When she gets a little better, the lady, she explained that at 8 o'clock she was listening to the news and everything was fine, but then she experienced a sudden dizziness. And this is the CT scan in the patient. Should be a movie. It seems the movie is not working. Okay, so I show you 4 slices at the level of the posterior fossa. My question to you is, we are dealing with normal CT findings. We have to deal with the hysterical woman. There's the phalanx calcification, no further abnormalities. There was a pseudotumor in the left pterygopalatine fossa. Or we deal with basilar artery thrombosis. Or again, we are dealing with a deep cerebral vein thrombosis. It's for you time to vote, but I will show you the images again. Excellent. I hope when you're at home, you're as good as when you're here in the audience. Of course, I only show you 4 images, but of course, with the clinical condition, when it fits together with the images, you see there's a small hyperdensity here in the basilar artery. You see a normal density over here, but at the adjacent slice, we see there's a focal hyperdensity in the basilar artery. And of course, when you have this dot in the middle cerebral artery, it's easy because you can compare with the normal side. Here there's only one basilar artery, so this is more easily to miss the diagnosis. But it should not be missed. It's a very important diagnosis to make. If you look at the enlargement, you better see these findings. Patient was referred to the Antwerp University Hospital, where arteriography was performed and the clot was removed. You see here, initially there's a stop at the distal part of the basilar artery, and when the clot was retrieved, we had the normal situation of normalization of the transition of the basilar artery with the normal aspect after clot removal. So, I hope you liked the cases, and with that, I thank you for your attention. I would like to give the microphone to Professor Daniela Breyer.